This is the Situation Room, the only way to start your day.
We will have the national chairperson of the Kenya Union of Clinical Officers, Peterson Wachira, will join us shortly. And we'll be looking at some issues as concerns the strike that was going on. Now where we are in terms of what will happen as concerns moving forward. So he'll be with us shortly. So even as we continue and wait for Peterson to get here and join us, there has often been conversations around whether strikes, industrial action actually work. And is it the language that is understood across board when you're trying to put a particular message across? A couple of weeks ago, the doctors went on strike, then retracted that strike action. The clinical officers went on strike last week, and then now have retracted that strike action in order for some kind of conversation to take place. The question abounds in terms of, does it actually work to say, you know what, in order for you to hear what we are saying, we are going to withdraw our services until and unless you get this done. Looking at what a clinical officer does, a clinical officer, many would argue, is
they run the health facilities essentially.
Yes, they do. It's look, when a clinical officer is there in a dispensary, for example, level 2, level 3 hospital, or dispensary. When you walk in to see the doctor, you see a clinical officer, but there is no difference between the clinical officer and the doctor in your mind. This is somebody who is going to check you, diagnose, and treat you, and give you the medication that you need. Most people will say, "Ni daktari."
Daktari.
All right. Is it possible to run the medical system without them? It is not, because they perform a vital service in terms of getting things done. But the thing is, we've often been met by a lot of industrial action coming from these quarters, because they say that, there are certain things that you should do for them that you actually have not done. And year on year, we find that they're saying, you know what, we're going to withdraw our services, because they are the ones essentially who run this thing, especially when in a facility you don't have a full-fledged doctor, as it were. Now, do these messages that are sent across when a strike action is initiated, do they work? Do they get us to the point whereby the authority in place will say, okay, guys, we would rather deal with the issue and make sure that we give their due rather than have their services pulled, because that will cause more harm than good. But the question is, does industrial action of this nature actually work? Does it yield results?
It does. It does. You see, once upon a time, there was no doctors' union. All these unions you hear of all the people who were in the health sector, didn't really exist. Somewhere along the line, well, it's not that they didn't want to have them. It was impossible to have them. The space for even thinking along those lines did not exist. When you hear of strikes, or what we refer to as industrial action, usually it's the last resort. The unions don't start by saying we're going to go on strike. They start by saying, why don't we talk and agree?
Yeah.
And in the cases that you've referred to in this country, the problems that are rising now is not that there was no understanding. No, the understandings were not honored. That's where the problem comes in. Meaning, discussions were had, and even as the discussions were had, certain things were understood to be at the very foundation of what ought to be done.
Yeah.
And both parties said, yes, we agree, yes. Do you agree? Yes, we agree. Will it be done? Yes. And within what time? Within this time. When can we expect it? Blah, blah, blah. That doesn't happen. So somebody goes back and says, we agreed on this, madam, good people. It hasn't been done. Please, is there a problem? Can you help us out? When it gets to a point where you can see no movement, you say, guys, you're not hearing us, so why don't we do something that will help you hear us?
That will help us hear us a little better.
And let's improve your ability to hear. And the improvement comes with the announcement, and it's a notice.
Yes.
It's not that we're not coming to work tomorrow. We're giving you notice. Come this day. If you haven't done this, and the other, as we had agreed, okay? Then unfortunately we'll have to down our tools.
There you go.
So it's last resort. Yes.
The conversation has previously begun. Well, Peterson Wachira is here, the national chairperson of the Kenya Union of Clinical Officers. Good morning, Peterson.
Good morning.
And Happy New Year officially.
Happy New Year. I think this is the first time I'm coming here.
Yes.
Thanks a lot for having me.
Thank you for being here.
It's always an honor and a pleasure
You're
to sit
welcome.
in this seat where the great men and women of this country sit and discuss national issues.
Wonderful.
And my apologies, I was a bit late.
That was going to be my next thing. After I had welcomed you into the thing, then I will now ask you why, but thank you for doing that.
It's things are hot. There was a meeting I really had to rush. I couldn't miss this one.
Understood.
For anything.
Well, I'm very grateful that you did that. And then also in the hot seat this morning. Let's see. Before we get into that, let's CT welcome you with today's proverb. Then you can tell us what you think about it. I think you might like this one today.
Yes, our proverbs for the whole of this week come from the Republic of Rwanda. Okay? Pregnancy and fire cannot be kept secret. Pregnancy and fire cannot be kept secret. That is the proverb for today.
True. I think quite literal interpretation would be there are things that however much you may want to hide, with time they are going to probably explode and everybody is going to see. Just like if you hide a fire, you're going to see a smoke. If you hide a pregnancy, then at some point it will be out there for everybody to see. But I think if I can link that with our issues, I must say that you cannot hide incompetence. Because I think the problem that we are having now, especially with the Social Health Authority, is incompetence. And I think now it is coming out for everyone to see.
When you say incompetence, what do you mean?
What I mean is that when you have legal provisions, you have policy or regulation provisions, but then the people who are there, they go against them, and using that, they find themselves sabotaging the system. That is the definition of incompetence, and that is why we have been very clear, asking the president, can you disband these administrative boards of SHA and have people who understand, and especially those who are doing direct administrations. And we are very clear with that, because if you look at the reason as to why we went on strike, because it's good for Kenyans to know, the Social Health Authority was put in place so that it can assist this country to get into the universal health coverage.
Yes.
By that I mean, it was supposed to facilitate access to health care. It was also supposed to ensure there is quality of that health care. And finally, that then they protect every Kenyan from financial harm as they access this good quality health care. But now, when the law says that once they come into place, they are going to recognize all the regulatory bodies that register practitioners and the facilities, all of them, and then take a list from them, put in their website and gazette. That is what is called empanelment. It's simply recognition.
Yes.
Once they do that, they contract the facilities, and once they empanel the practitioners, they can be able to see patients under them. Then they sit in and say, we are a bit lazy. We cannot handle the about 10 or more regulatory bodies. We just need to use one, which is KMPDC, which only registers 2 of the cadres, medical officers and dentists. Then you lock everybody out. Then later you come to realize that it's clinical officers who actually see almost all Kenyans, and now they cannot be able to see them through the system. And everybody is crying, we cannot be able to utilize SHA because Clinical Officers Council, which registers us, has been locked out. And so all of us who have been registered under the Clinical Officers Council then are unable to see patients through the Social Health Authority. But now, even worse, is in October we write to them. They do not respond. We go to an extent of having demonstrations. We say, no, we don't want to down our tools. Why don't we first demonstrate? Probably the Vuvuzeras might make them think better. We go there severally in December, until we reach a point where we have to go on strike for them to see the sense. And this is now the time that they're empaneling us. And that is why we are saying that it's either we are having incompetence at the level of the people who are implementing these things at the Social Health Authority, or we are having selfish interest, and either of those should be a ground for these people to be censured or to be sacked and other Kenyans to replace them.
So Peterson, sorry. Go ahead.
Peterson, one would assume that by the time we were putting in place universal healthcare, SHA and SHIF, that organizations or people like you would have been consulted before this is actually put in place, because you're talking about access to healthcare for the 55 million Kenyans that do exist in this country. Was there any communication that happened with you?
Yes, I can say to some extent we were involved as stakeholders. When these laws were being drafted, we were there. When the regulations were being drafted, we were there. There are many things that we raised that were never changed. And I even remember at some point, it was said as an achievement that we thank the parliament because it has passed the laws without changing even a comma. It was,
Yes.
Some things really are baffling. That was seen as an achievement. Well, we as the stakeholders, we had challenged many things. We had challenged the issue of the subscription or the contributions to the fund.
Yes.
And we had said that, why, if you're saying 2.75 for everyone, why are you capping? Because the person you are saying to pay 300, the lowest, is actually paying the highest percentage. Because it means this person's percentage maybe was coming to 150 shillings. The only person who pays 300 is the one whose 2.75% does not reach 300. So if you are 2.75 was at 150,
Yes.
you pay 300, that is double of the 2.75. So you are paying 5.2 something
Right.
percent. The other thing we said that the funding model of the social health insurance was not in line, was not aligned to the better plan of the president of prioritizing primary health care and prevention.
Which is one of the things he stated very clearly in the plan. Okay.
Yes.
Cool.
And the reason as to why we said this is because if you want to know the priority of anyone, just look at where their money goes to. If you look at the funding model that is in the Social Health Insurance Act, the primary health care fund is supposed to deal with prevention and then the curative at the lowest levels, dispensary and health centers. Where does the money come from? It comes from Parliament. How much was allocated? 4-point-something billion. Then curative is from sub-county hospital level 4 up to level 6. The funding for that is what we are contributing, the Social Health Insurance Fund. That is the one that is called SHIF, the second fund.
Yes.
That one we are contributing around 133 billion. That is for curative. And then you have the emergency and chronic care. That is now an addition to that. So for prevention and the primary care, we are giving 4-point-something billion. And we are saying our priority is prevention, but then for curative, we are giving 133 billion.
So where is the priority?
So the priority is curative. And so we were asking, why have a ceiling up there at the curative level where all the money is? Why not remove the ceiling and allow the money to pour down so that we can start from prevention?
Actually, it's still more interesting in this sense.
Yes.
If you allocate more money to the preventative arm of this system, it means people will not need to access that curative because there will be nothing for you to cure. It will have been sorted out or it will be reduced significantly. But this argument has gone on for a while though. So it also begs the question, when it is actually patently obvious what ought to be done and then you don't do it, then what are we seeing? What exactly are we being told?
I think we should have some principles and laws in this country where when you are in certain leadership positions, there are some kind of businesses you shouldn't have. I don't want to expound, but we shouldn't have, if I'm a CS,
Okay.
and I'm not saying that a CS.
We're not saying that you are. Okay.
Yes, it's just an example.
Of course.
You shouldn't have a private hospital because the policies, you're supposed to be at a point where you're making policies that may influence the funding of health, and you may want to probably take it to where it is going to benefit you. But I'm just saying as an example, I'm not saying our CS has a hospital. And I think what I'm trying to say is that I think the issue is interest. Because if you look at the Cuban model that we wanted to adopt, if we funded our preventive, our primary health care very well, and we were having a nutritionist You are having a public health officer, a clinic officer, and a nurse in the dispensary in the village. And they go into every homestead. They go and look at the risk factors from the father to the youngest child. They go to the schools and do the same. The public health officer goes into the community, looks at the water sources. How do you dispose your waste? How do you dispose your excreta? We will be able to reduce the communicable diseases. We are still losing so many kids with diarrhea and vomiting because of the sources of water. If we had that model and funded well so that we have that preventative bit, and by the way, that cannot be done by the CHPs. CHPs are very good, but that preventative bit that I'm talking about, because right now we are not preventing diseases. We are screening. We are looking for the diseases. What we are calling preventive, we are saying CHPs are going to come and take some samples and see if you have diabetes, if you have hypertension. But nobody is coming to tell you that you have risk factors. This is what you need to do. So we are not preventing. We are just screening to get these diseases and then cure them.
Yeah.
So we need to refashion our system so that it can be preventative in nature, and then take enough funding and enough technical personnel. And the technical personnel who are needed there are known, because we were taking Cuban model, but at some point we decided to twitch it. Only then are we going then to bring the cost of health down, and then we will be able to manage it.
Yeah. So, Peterson, even with this strike action, many would imagine that it was just about the CBA for clinical officers. But obviously what is coming into play here is that it's difficult even for medical practitioners to do their job within a system that you clearly have talked about that is flawed. So it's beyond just increase our salary, it's beyond improve working conditions, but you're saying across board, improve this system so that it becomes easier also for us to do our job and to provide the much needed medical care to Kenyans. Am I right?
Very true, because we had two issues. One was on the Social Health Authority exclusion and discrimination, and that is purely for Kenyans. We are basically fighting so that we can be able to see Kenyans without them suffering from financial harm as they do that. Of course, the second thing now was about breach of the return to work agreement. And I think CT really summed it very well. I think what he said was perfect. It was a very good deduction of what happened.
Please repeat that statement.
You know, he's a wise man. Yes. Because, in 2024, we had the longest strike by clinic officers in history since 1928, when we started working in this country. We have never been on strike for 99 days and 121 days under the national government. Why did we go on strike? Because there was an order from the court for the employers to sit with us and conclude a CBA, which they didn't. So we actually went on strike to enforce an order of the court. During the strike, when the judge still realized that the strike was taking quite some time, the judge ordered us to sit down and enter into a return to work agreement and draw a framework on how we were going to resolve these issues. So we sat over several days with the Council of Governors, high level, with the Ministry of Health, high level.
Yeah.
And we drafted a framework that was supposed to end by September. We should have resolved these issues. We took the framework back to the court. And I remember when we went to the court, the judge asked two questions to our lawyers, the lawyers of the union and the other side. And the judge asked, did you do this in good faith? And they responded, yes. The second question was, so are you going to implement this, or are you going to come back here accusing each other that you never implemented?
Yeah.
And they both said, no, we are going to implement. Then we find ourselves in January, the county governments having not implemented. So majority of them having not even done 10%. A good number had done probably one or two things, but a majority had not done much. But I think I must commend the ministry and the leadership then, because that side was on the Public Health and Professional Standards, PS.
Yeah.
that they have done 80%. They have promoted. We have a comprehensive medical cover. The CBA is almost done. It's actually the Treasury and the SRC that is pulling us back. So the ministry has really tried, except now on the issue of the universal health coverage and global fund. But the counties were really lagging behind. So then we go on a strike, and then now they come in. We had first given a notice of 14 days.
Yes.
And we even wrote to them. And when we did that presser calling for the strike, we were very clear that we have no intention of going on strike. We don't want to go on strike. We are giving 14 days so that we can sit down and resolve these issues. Then 2 days to the strike is when we are having our first meeting, and we do not have to have solutions. That is why we decided to get into the strike, and especially on the issue of SHA, because you're asking them, why would I sit in a facility when I know that any Kenyan that comes, I cannot see them using the Social Health Authority number or card or whatever, and they have to get money from their pocket when they have already subscribed to this insurance. And we said no. Until we are at a point where we can be able to utilize the Social Health Authority, the Social Health Insurance, to see our patients, then we are not going back. And we gave that as a bare minimum. And now that has been done after the strike. But of course, the other issues, we have also seen a lot of goodwill from the Council of Governors. I must also commend them. On this issue of SHA, they are the ones who have actually shown leadership, which is expected to come from the ministry. And they are the ones who said, these people, they work under us. They are the ones they are the clinicians on the ground.
Yes.
And our people are suffering. You have to. And mind you, there is no legal handle. There is no legal challenge. If you look at the act, there is nowhere it discriminates. There is nowhere it says it is only this one you can consider and not the other.
And the other.
If you look at the regulation, it is explicit. You must recognize all the relevant regulatory bodies.
Okay.
So some people just sat in an office and thought probably the regulatory bodies might be too many for us. Why don't we pick one? And that is why we are saying the president needs to reevaluate, because he goes out there, promises Kenyans that SHA is working.
Yes.
But sometimes the reason as to why you see Kenyans angry is because he says it's working. Because in his mind, he knows
He's
he
been
has
told
the
it's
policy
okay.
right.
Yeah.
But then the people implementing here are self-sabotaging the system. And so it is not working for the people on the ground. So the president doesn't understand why people are saying
This thing is not working.
it's not working. And that is why we are here to tell him. It is the people in those offices who are actually sabotaging him.
Peterson Wachira is the national chairperson of the Kenya Union of Clinical Officers, and we're talking about the reasons as to why there would be strike action and what the call is for understanding in terms of what needs to happen. That strike notice in certain parts of the country has been called off. We'll look at some of the intrigues around that and then what would happen coming into the future. And then also we want to get a clear understanding. I mean, again and again, Peterson, it's not too much when we share information about, the role that clinical officers do play within the medical system. And even as we look at the demand on the system, the next few minutes of this conversation, I think it's important for us to, again, look at the role. I mean, because you represent clinical officers within the entire, medical spectrum. But I think it's important for us to look again at the role that clinical officers play, because that would then help us see on a broader, picture why then it is important to make sure that they're able to keep playing that role.
Very well. So clinical officers are health practitioners. We are found in around 87 countries across the globe. Some people think that clinical officers are only found in Kenya.
And they only trained at KMTC.
Yeah, we are called primary level clinicians. Albeit we have different titles. Actually, our count is 34 different titles for the 87 countries. And that is one thing that at the international level, because we have an association, we are trying to harmonize the nomenclature so that we have one title. The other thing I can say before even stating the role is that the US and the UK benchmarked from Kenya to start their physician associate program.
That's what they call it.
Yes, people are used to thinking that it's only Kenya that can learn from Europe and the US. When they were benchmarking, I was in that meeting. They even took our curriculum and it is being implemented there.
Wow.
So that is the equivalent of clinical officers in the US and in the UK. So clinical officers, we usually work as primary clinicians. Primary clinicians means the first clinician you are going to meet when you get into any hospital. When you go to level 2, level 3, we are the only clinicians there. When you go to level 4 up to the level 6, mostly you're going to find us in the outpatient and in the specialized clinics and in theaters, depending on the specialty. So when I talk about the specialties, we have around 20 of them. Things like ophthalmology and cataract surgeries, 98%. If you have an ophthalmology or cataract surgery, 98% chance is that is a clinical officer.
Okay.
Things that to do with the ENT, ear, nose, and throat. Things to do with anesthesia. When you have to be anesthetized for surgery to be done on you, there is a 95% chance that that person who is doing that is a clinical officer. The same for oncology services. We are the ones with the specialists. If you go to oncology centers, the specialists you are going to find they are giving you chemo and the other things is mostly a clinical officer. I think for a long time we have not had that specialty for doctors. Probably it's the first, they're having the first class or the second. It has been the clinical officers. And the same for the other many specialties. So when you go to the HIV, TB clinics, when you go to the NCD clinics, the people that you are going to get there, or majority of them, will be the clinical officers doing that. And with the new system, now with the new referral system, where you have to go to level 2 or level 3 before you are referred, 100% of Kenyans now have to pass through our hands before we can refer them upwards. So that is the scope of our role. And now you can imagine when that type of a cadre is locked out of the social health insurance,
Right.
and then you tell Kenyans, can you prescribe to this insurance so that you do not pay?
And you see, when you talk about the importance of clinical officers in our health sector, please remember that since devolution, they've had 100 strikes. That tells you they've not been listened to 100 times.
So what makes it possible that they would listen at go 101?
Yes.
The unfortunate thing with this country, number one, we are very superficial. We have what I like calling superficial politics. Don't look for it in any dictionary. It is not there. But the superficial nature of it is we are only disturbed by what seems to threaten our image politically. And that is why it is only the strikes that are working. They do not work because these guys want to work. They work because people feel that they are threatened. Their image is being threatened. But as long as you do not do that, and that is why we always do letters. The correspondences, they don't care. They don't even answer. Until you threaten their positions, you threaten their comfort, that is when they are going to act. And everything that we have gained, I must say, since the 2010 constitution, before 2010 constitutions, we were like the military. We were not allowed to strike. We were not allowed to have unions. Since 2010, we have gained a lot. And by saying we have gained a lot, I'm not only talking as a clinician, I'm also talking as a patient. Because at one or the other time, I'm a patient, my child is a patient, my relative is a patient, or my friend. We have been able to improve so many things. We have improved the number of clinic officers that we have in the system. Of course, we are not doing very well because by now we are supposed to be 22,000 in the system. As per the statistics from the Ministry of Health, not from the union, though we are only around 7,000. So it means every one clinical officer works for 3 clinical officers. And that is why you'll find, at some point we looked at the Nakuru PGH, and we found a clinical officer had seen 150 patients
in a day.
within 12 hours.
12 hours.
And that is pure witchcraft.
It's something on drugs, that's for sure.
And if you don't
No
do
pun
that,
intended.
the MCA will be there slapping you.
Yeah.
Everybody will be on your case. Why aren't you using patients? And the problem is because in a day, as per the WHO, if you give a patient, you are supposed to take at least 15 minutes with a patient so that you can listen to them. You can be able to diagnose them without, when you're not in a hurry, so that you get it right. You are supposed to only see between 35 and around 45 patients. This person who is doing 150, I can assure you by the time they were getting to 60, they were fatigued.
Because look, if we do the math, Peterson, if you're saying that you're supposed to spend 15 minutes with a patient, and if you're doing just 100 patients, okay, I'm even saying just 100, it's ridiculous. 100 patients at 15 minutes is 25 hours.
Yes.
It's more than a day.
It is.
So, two things are happening here. Either you're rushing through and you're not getting a full, comprehension of what's going on with the patient, and there could be things like misdiagnosis.
Yes.
Or you are not seeing the number of people that you should see. So, how do you even begin to do 150 is more than 25 hours?
Actually, there's a problem.
There's a big problem.
The moment you're talking those numbers, you are going to misdiagnose.
Yes.
You are going to misprescribe. There's so many things simply because of fatigue.
Let's talk about when you're not even you as an individual, when you haven't gotten enough rest.
Yes.
You're not at your optimum.
True.
So this is a space that requires you to be at your optimum in order to see where there's a problem based on what somebody has told you, and then you then go ahead and diagnose. So we're dealing with a pressure cooker situation here where clinical officers around the country, for number one, not enough in terms of numbers.
True.
Number two, have to see the health burden is already so great. And you don't have the time or the resources to deal with everybody as you should. If we're dealing with a today problem where every clinical officer is seeing between 100 and 150 patients a day, that's a disaster.
And then do also remember that they're dealing with patients. The things they go through alone requires you to rest.
Oh no, we don't even
Mental
deal with the
health
things that
and
they're going
whatnot.
through. We don't know, please. We don't have time.
Nobody cares for
we
the
don't have
carer.
time to think about what the carer is going through. That's not your problem.
And that is why politicians will never come to the public facilities because they're the decision makers and they understand these things. They know that the people there are fatigued. Probably they are going to misdiagnose you. They do not misdiagnose. They do not do medical errors because they are incompetent. They do medical errors because they are fatigued. When you are fatigued, there are several symptoms and signs you are going to have. You'll become irritable. Have you heard people say that our nurses are very rude?
What are you talking about?
They
Just the
slap
other
you.
day, we heard a story of a gentleman who arrived at the front door of a facility with a broken leg, and the lady at the front desk was literally watching him. Her eyes were open. If you looked at her, you would imagine that she was alive. But there's no life behind those eyes.
Yeah, and sometimes, as much as I am not supporting the rudeness and the other things, fatigue, when fatigue sets in, even if you are to do a simple Google search about the signs and symptoms of fatigue at work, you see irritability, you'll see mental cloudiness, you see many other things, including stress and depression. And this is what our nurses also are suffering. So this is what many of the clinical officers and other health workers in public facilities are suffering from. And we are trying to tell them that we should stop looking at health workers as a liability. We should start looking them as a development. And there is an opportunity actually with the Social Health Authority, because right now, if you have more health workers, it is going to give you more money as a county. And this is the reason. The way we have oriented our social health insurance is such that the patient has the power and has the discretion to look for quality. So the patient is allowed to go to a level 2, level 3 of their choice, whether private, public, or mission. So the patient will follow where the quality is. And the money is going to follow the patient. And so if the public facilities, because patients will not go to the public facilities, in level 2 you only find a nurse. In level 3 probably a clinic officer and a nurse. You don't even have a lab tech. But if we can have at least a clinic officer per dispensary, the nurse, then you have a laboratory technician, so that at least you can diagnose quite well. You improve the quality of the diagnosis and management at that level. You are going to pull patients back into the public facilities. They will be followed by that money that then you are rebated by SHA, and you are going to get more money for FIF. You know, you have an FIF bill where you are supposed now to retain that money at the facility level for the improvement and buying the equipment.
Yeah.
And with the time then, that is going to build the health system in the public sector and make it better. So there is an opportunity, and employment of more health workers at this point is evident that it's actually a development, not a liability. But then our politicians sees that as a liability, and that is why they want to minimize that cost as much as possible. And in our return to work agreement, that is one of the issues, and it's one of the issues that we're also discussing. But then the problem is that from our PFM Act, the Public Finances Management Act, the capping of 35 for the recurrent expenditure, and then you push the employees in that 35%, and keeping in mind that when the devolution was happening, counties had only been given money for the employees. So at some point it was actually almost 100% when they were starting.
Yeah.
And a bigger chunk of the money goes to employees. So you'll find most of them have surpassed that. It becomes an audit query. And that is why we are saying that there needs to be a revision on how we look at that. Either we categorize health workers as development expenditure so that they come into the other side of the 65%. If that cannot happen, then why don't we then have a commission that will be able to hire and manage, but then that can sit very well with the counties?
Yeah.
And we had structured that. We presented before the BBI team during the time of BBI, and we said a health service commission does not mean that now we are going to centralize health services. We can actually still have the counties run their functions, but then when it comes to employment, so that we only have a commission that is not restricted by the PFM Act. We have a commission where if, let's say, Nairobi or Kisii County wants to employ, it will send a request to the commission and say, I need 10 nurses, I need 20 clinical officers, I need medical
and the commission now can?
The commission hires, sends to that county as per their needs. Then within the county, they can manage them within the county. You can transfer, you can discipline, you can do whatever. When they need to move from that county to another, they apply back to the commission so that the commission can take them to the other and probably exchange. When they need to terminate, you also take back. It is possible to do that.
Yes, it is, but also it will also ensure that the needs that each county would have, because you cannot say all counties have the same need.
True.
That it is understood and in that manner also balanced. See, people who want to go back to that centralized system look at it from the time when all this was centralized, and the idea was everyone can benefit as a result of this. Because with the current system and the way it goes about it is, if you come from a community or you come from a county where very many people have gone to school or have trained as clinicians, you have an advantage. You will have more clinicians. If you haven't, then I think
then you will not have.
Well, you'll have a problem. You will have a problem.
Yeah.
You will employ, but you're going to have to supplement it by employing from others.
Yes.
And yet, what you then have is a situation you probably don't want to create, where people assume that any position that is vacant must be filled by somebody from their community. You see? Now, you cannot do that to health service, because then you will disadvantage very many communities in this country. Yes.
The hope is, as you continue to have such engagement, is that it will fall on listening ears. So that would be the next question: is that who's listening now, and that with the developments that we've seen over the last few hours, you had a meeting this morning as well, but where are we now?
Since we started the strike, we had had quite a number of meetings with the CS Health, with the PS, with the Council of Governors. And the issue of SHA has been resolved. As we talk, they're inputting the data. I think some of us now can be able to use SHA. And we are told by the end of the week, everybody should be able to do that. So we can say that is being resolved. But on the issue of the breach of return to work agreement, we have agreed. We suspended our strike yesterday after an agreement that within the next 21 days, we will be able to finish and sign off on the CBS, both at the national level and the county level. And also implement the other things in terms of promotions. And you can imagine within the few days that we have been there, a few counties are already almost done with the promotions and designations and the other things. So you wonder, do you have to wait for us to go on a strike so that you can effect something that you would have effected without having to disrupt
It would appear so.
Yes.
It would appear so, because even the government that preceded this one seemed to have had similar hearing problems.
True.
Yeah, because you are told, it is repeated, and yet you are determined that you will only hear when you have a gun to your head.
Yeah.
Yes. It seems that is the path that they have chosen, because the alternative has always existed.
Yeah.
So you always ask the question, why do you wait until the water is boiling?
Another question would be, I mean, health is a fundamental right in the Constitution. It is what all of us ought to receive at any given point. And when we have 100 strikes, now we're going to the 101, you've not been listened to, begs the question, why does it seem as though the leadership that has been there, Uhuru Kenyatta, now William Ruto, are not taking the responsibility of giving healthcare to Kenyans as a matter of priority? Is it not a priority to them?
It's a priority in conversation.
In conversation.
Yes. When
And in manifestos.
Yes. When it's spoken of and it's written down, it is a priority.
It is a priority.
You know, when you talk about primary healthcare, you know, there's a process that began quite a while back. It was called the Integrated Community Case Management. Research was done on it. It was understood. There's even an implementation document where the minister said, this is how you are to. That is supposed to take care of primary health care, even at the community level. Now, the cost of actually implementing it was even worked out and piloted. So it is known. So you actually wonder, wait, counties have money for all manner of things.
Yeah.
This is something, okay, let me take a few steps back. What it demonstrated was that you could reduce the attendance of patients, the hospital attendance, by 75%. Now, the pilot was on pneumonia, malaria, and diarrhea. Okay? Just those three. But it was proved that 75% of people who would ordinarily have gone to hospital because of this could actually be managed at that community level. Now, you want to ask, why do you wait for people to get to that level? Because it's going to cost you more. The condition that began and could have been managed very easily at that level now becomes serious. This person has to be actually hospitalized. They have to be given medication that they didn't probably need to be given at the very beginning. This is a story that seems to permeate our healthcare process, because, by the way, when I say it has been documented, the ministry has documented all this. There's even an implementation plan. So you wonder, okay, why haven't you implemented it? Because you clearly understand it. And by the way, the implementation plan that is current is the year 2022 to 2027. I would like someone to tell me how the implementation is going on. Yes.
Yeah.
Because this very thing we're discussing here about SHA would have been taken care of with this.
And there are very many of those policies you're talking about.
Yes.
Other countries like Rwanda has borrowed, and they are doing actually better than ourselves. But just imagine that as we sit here, we don't have the public health officers taking samples of the water from the wells where communities drink from. We do not have public health officers going around and looking at the rivers where people get their water from. We do not have nutritionists and clinicians or nurses going to schools and looking at which child has malnutrition.
Yes.
Look at the cases of rickets.
Yeah.
Why is it that, if you find a child that comes repeatedly with pneumonia and diarrhea and vomiting, if you evaluate them well, you're going to find that they have rickets.
Yes.
Meaning, rickets is a kind of malnutrition.
Yes.
It's
It
a
is.
case of calcium and vitamin D.
It's like a manifestation of that malnutrition.
Yes.
Yes.
And of course now lowers the immune and they come with other conditions.
Yes.
So if some of these things, if we had what we call the community health programs and the family health programs at the preventative or the community health level, These are things you'll be able to pick at home. These are things you'll be able to pick in school.
In school.
You'll be able to correct them before they get to that stage. And as you said, 75% of those patients will not come to the hospital.
Because you've prevented it at that level.
Yes.
And you've been able to look out for what it is. So, I mean, it is clear that when we started this conversation, we talked about the fact that, you're going to put your money where your priority is.
Yes.
Right? And your priority doesn't necessarily mean that is what it should be.
Yes.
Your priority could actually change. So if we looked at health and we say that preventative health is where the world is going, where anybody should go. It's cheaper, it makes more sense. On the whole, it comes together better. But curative is where most of the money goes. But look at what you're talking about now. Clinical officers best placed to do certain things when it comes to preventative health, which is the cheaper option and the more holistic one. How do you get folks to see that? I would imagine that they do.
Now, you see, people restructure systems to suit their interests because in no uncertain terms, right now, we are in a curative system. Let nobody lie that we're in a preventative system. Even the CHPs that we got, that we say that they are there to prevent, they are just there to scout for those people who have diseases so that we can cure. So they are just as a facilitator of the curative system. And we must be able to restructure. And the funny thing is that when we raise these voices, some of us, we are seen as if we are opposing. Instead of people saying that we are giving positive criticism so that we can be able to better healthcare. And I think what we really need a leadership that listens, that can be able to bring the stakeholders to discuss the fundamental issues about the structure of our healthcare. We start from there. Let us forget about the funding and whatever else. Let us sit down and look at how do we need to structure our health system so that it works for us. Because the health system, the kind of health system we have right now, does not work for us. Yes.
So, in the next couple of days, what do we hope to see?
In the next 21 days, our expectation is that we are going to have a CBA. All the counties will have promoted, designated. We will have a medical cover. We will have a budgetary allocation for absorption of UHC, harmonization of their salaries, absorption and payment of their gratuity. We have already written to the Treasury. I think the budget policy came out and they were receiving inputs.
Yes.
And funny enough, we realized there was no money for UHC, yet their contract is ending next year. So we have written to the Treasury. We have written to Parliament on the same. But of course, if after 21 days that does not happen, we'll be back on the streets.
I hear you. One can only hope that, the listening ear will actually then give to the doing hand, because that's what needs to happen if we're really talking about getting a health system off its knees to standing on its feet and, taking a walk. Peterson Wachira, the national chairperson of the Union of Clinical Officers, has been our guest this hour. Let's see what happens as the next few days unfold. Asante sana for being here this morning. And thank you for being part of the Situation Room, Kenya's biggest conversation this Thursday.
This is the Situation Room, the only way to start your day.